Good morning or good afternoon, everybody, depending on where you're joining us from. Um, I am Antoinette Gravel-Willette, and I'm the program coordinator for Mom Stop the Harm currently. And in a moment, I'm going to introduce Elder Susie, who will start us off in a good way, and then I'll introduce our speakers just to give a little bit of the lay of the land. Um, we we will have our speakers present for about 45 minutes, and then we will be taking questions. So welcome everybody. So glad everybody could make it. I know here it's really nice out and it's sunny and it's warm and I mean, we've been waiting for that for a long time. So just very happy that it's here. So I was saying before we jumped on, I think maybe some people are taking advantage of the sunshine and knowing that they can review this later. So um, I would like to introduce Elder Susie now. Um, and it's a real honor to introduce Susie. I've known Susie, I was trying to figure out for how long. I know it's been at least 15 years, and I learn and I continue to learn so much from Susie, and I've often heard her say that stories are medicine, and and came to know and hear that in many spaces. So I often reflect on that, and that's something that's really touched me, that continues to touch me because um, it is medicine as we hear and as we share with one another. So I felt that was quite profound. Um, and Susie also taught me my first drum song and all the meanings that went with it. So, um, Elder Susie, I welcome you to open.
Thank you, Antoinette, and good morning, everyone, or good afternoon, wherever you are. And so I'm really thankful to be here with you this morning. I'm originally from Churchill, Manitoba, um, and have resided here in Brandon, which is Treaty 1 and 2, I guess, Treaty 2, and for almost 40 years. In August, it'll be 40 years. So I'm thankful to be here with you all this morning, and I'll say some words in my own language, and then I will do an acknowledgement that I've come to know over time and share wherever I go, and then a welcome song to welcome us all to this time together. Gisemantu, ginanaskamatanana nos kagisaga, sawanamenan gamino bimatsia, Wichihinan ganawanamenan anos wabahe gumadahtagisagaw, Wichihinan ganawanamenan Gahkanoninanan Gajwasamisa, Squawak, Nabewak, Squashisak, Nabesisak, Egomaga Gakino Wenege, Heyapajiguta, Anos, Minanan Inanosoen, Ego Mino Machi Hoen. So I want to acknowledge the ancestral territory of the Indigenous nations who were here on and continue to be on these lands. I want to acknowledge the 600 plus Indigenous nations that were here across Canada prior to European contact. Unique and distinct societies with their own languages and systems of governance, living, surviving, and thriving peoples who knew the land, the waters, the skies, the patterns of weather and animals, who looked after themselves, each other, their communities, and their nations, and who saw themselves as a part of creation and lived as such, always mindful of the generations to come. And so today we look to the east, the south, the west, and the north. We acknowledge the Indigenous nations across the land and their ancestral story, truth, and wisdom that has carried over time to this day. We acknowledge how the story unfolded and changed over time. We turn full circle to the east, and we acknowledge all the nations who now call this land home, those who came as guests, visitors, settlers, newcomers, immigrants, refugees, post-contact nations. And we acknowledge their story too, and all that they bring and all that they brought here. May we be mindful of each and every one of our stories and the connection to the Indigenous worldview story that was and is happening here. So I give thanks for each one here, the story of each one of our lives, all that we hold and carry, and the journey that we are on. And so I say, Egwisane, Ninanaskamon, Gakano. That's thank you. I am grateful. All my relations. So this song that I will sing is called the Welcome Song, and it was sung by an elder in another province at a conference, and a few of our women from here were there and offered tobacco to bring this song back. And I love this song because it is sung to welcome a new day. It is sung to welcome the spirit of each of the directions, including above, below, and within. So I'll sing it 7 times. And if you feel free to join, please do so. It's a simple verse. They're all the same. And I think of the welcome song as a song that grounds us and centers us to this time together and the conversation we'll have. And also to welcome the spirit of what any one of us needs here this day, whether it's a spirit of peace, of hope, of healing, of love, of joy, of learning, unlearning, and relearning. And so I'll sing the welcome song. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Yeah, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. Oh, hey. Oh, hey. Yeah, yeah, yeah. Oh, hey. Thank you.
Thank you, Susie. I always hear that song and I just take it in, and I love when you say that it's there for whatever each of us need for this day. So every day's a new day. Sometimes I think I could probably, you know, have that song sung different times during the day, welcoming, the different seasons that come in throughout the day. So thank you for that. Okay, so I'm going to introduce our topic now. So I'm just going to read some of it because there's no way I would remember it all. So now a decade into the drug poisoning crisis, most attention is focused on urban areas of Canada. Yet data indicates that rural communities are facing increased drug-related deaths and limited access to evidence-based services. As a result, many families are stepping in to provide support for loved ones who use drugs, but their work is often invisible. Today, our presenters will give an overview of findings from a recent community-based research project with 31 family members providing care for loved ones who use drugs in rural prairie communities. conducted in partnership with Mom Stop the Harm. You can expect to learn more about how rural families and communities experience the toxic drug crisis, the care of the work being provided by rural families, the personal toll of providing such care, and family suggestions on what would make life better for people who use drugs in rural settings. So it's a pleasure for me to introduce Dr. Holly Mathis. Is it Mathis?
Matthias.
Matthias, thank you. Um, and Dr. Holly, I'll just go with
Yeah.
is an assistant professor of family science in the Department of Human Ecology at the University of Alberta and research scientist within the Inner City Health and Wellness Program. Holly's program of community-based research explores how families encounter and experience emerging health and social issues, such as toxic drug supply. Raised in rural Nova Scotia, Holly especially enjoys conducting research that supports and celebrates rural families and their communities. Holly holds a PhD in public health sciences from the University of Alberta and lives on Treaty 6 territory. Welcome, Holly.
Thank you.
And next, I'd like to introduce Jen. If you could just say hi so we could change the screen and see Jen.
Hi, I'm Jen. Thank you for having me today.
Thank you. So Jen McCrindle is co-founder and communications lead of Reclaim Collective. Jen has been actively involved in national and provincial harm reduction work in Alberta since 2012. For the past 7 years, she's worked as a frontline rural outreach worker with Turning Point on Treaty 6 and 7 lands, which, for those of you that don't know, are central Alberta. She's been involved with several projects as a community-based research assistant, including Canadian Association of People Who Use Drugs Best Practice for Engagement and Inclusion. Jen lives and works very rurally and is an advocate for improving substance use services in small communities. So I will pass it on to both Jen and Holly. Welcome and thank you so much for being here and being willing to share all of the findings. I know for me, I live rurally, and my guess is a lot of people that are here also do, and it's very dear to our hearts. And even being acknowledged as this is even a thing, I think is very important. So, welcome.
Thank you, Antoinette, and thank you, Susie, for opening us in such a good way. So as Antoinette said, my name is Holly Matthias. I'm an assistant professor of family science in the Department of Human Ecology at the University of Alberta. And I'm really excited to be here today because Mom Stop the Harm was such an incredible partner when we were doing this research over the last 5 years, which is hard to believe that it's been such a journey. And I'm so excited to also be able to co-present today with Jen McCrindle, who's been involved with this work as well over the 5 years. And Jen, as was mentioned in her bio, is a co-founder of Reclaim Collective. And so we are really excited today to share some more findings from this community-based research project that really was aiming to better understand just what exactly families are doing in rural communities to support their loved ones who are using substances. And so we've already been opened in such a nice way, but I do want to acknowledge that Jen and I are both situated on Treaty 6 and 7 territory. And because we'll be talking about substance use and drug poisoning today, I do also like to acknowledge that First Nations people are disproportionately impacted due to colonialism, racism, and structural discrimination. And so when we're thinking about doing land acknowledgements or thinking about reconciliation, to me, it's always a really important thing in this work to be able to acknowledge that there are groups that are disproportionately impacted, and that it's really important that we work together to better support these populations as a part of reconciliation. And I also want to just add some acknowledgements before we begin as well that it's not just Jen and I who have done this work over the few years. We've had an amazing team of partners from across the Prairie provinces. I also want to acknowledge the 31 participants who so generously shared their stories, because without people who are willing to share their stories and experiences, research like this just isn't possible. And also want to thank the many funders of the work over the few years. And so, to begin, because we're going to be talking about unpaid care and caregiving today, I'm curious if people maybe have any thoughts on how many Canadians are currently providing unpaid care or support for a loved one, not just around substance use, but in general. How many people do you think are providing unpaid care? And you can put it in the chat, you can shout it out, whatever your thoughts might be.
Millions.
Millions. Yeah. Yeah. Millions is right. So in Canada, at any given time, about 25% of Canadians are providing unpaid care. And so, if we think about 25%, that's about 10 million Canadians every day who are providing unpaid care. But we also know that 50% of people will do this in their lifetime. And there are certain groups that are more likely to be providing unpaid care than others. So we know that about or over half of the population, the caregiving population, identifies women. Most are between the ages of 25 or 64 years old, which is sometimes called the sandwich generation, because often they're caring perhaps for little kids, as well as maybe aging parents or their partners. We also know that just under half are working full-time jobs in addition to providing unpaid care. And around 6% of people are providing care to someone with a mental health or substance use concern. I do like to note, though, that this number is probably quite a bit lower than the actual number of Canadians who are providing care for a loved one. Some reasons for that is that sometimes people won't identify with the term caregiver, or they might feel like the support that they're providing for their loved one is just a normal part of their family life. And so, for example, in Ontario, there was some research that was done, and they found that around 55% of people who would be considered caregivers don't actually use that term for themselves or see themselves in that way. And so, although we have these numbers, I just like to point out that I think there's probably a lot more people who are providing unpaid care every day. And so this is really important because we have so many Canadians who are doing this unpaid work, and it is critical to supporting our economy and our healthcare system. And so every year, because families are putting in all this extra care and work, it's saving our healthcare system around $98 billion every year. And so to put this into perspective, as I showed on that last slide, about 44% of Canadians work full time in addition to providing care. And on average, caregivers are providing around 5 hours of care each day. So if you can imagine that, that's like working your full-time job, coming home, and then doing a part-time job, which is caring for your loved one. And a lot of people do this out of um, responsibility or because they want to provide care for a loved one. But it still is a lot of time that's spent doing this and in a way that's not being recognized as much. Let's see here. All right. And so, what is the cost of care? So, in Canada, we know that caregiving comes at an immense cost. And so,
Hang on a sec. I don't know what happened or if it changed on everybody's screen, but I see like I can see there. That's better. Whatever
okay,
you did change.
okay, sorry.
Okay, thank you.
Okay. So yeah, we know that there's an immense cost for caregivers. So we know in a recent survey that was done, and these findings were just launched earlier this month, that around 77% of caregivers are reporting negative impacts on their well-being. And another about 49% have talked about having really extensive financial strain because of the care that they provide. And interestingly, this number is higher among people who are providing care for someone with a mental health or substance use problem. And now, what I think is really interesting is that in this survey, 61% of caregivers said that they don't feel supported by the government. And interestingly enough, this was consistent across provinces, across political parties. And so it points to the fact that care in families is really a nonpartisan issue in many ways. This is something that people are feeling universally, and that they're saying that they need more support in order to be able to be well and to support their loved ones. And because we're going to be talking about care in rural places, I think it's also important to note that 20% of caregivers live rurally. And so this does make sense because we know that when people have trouble accessing formal supports and services, which is often the case in rural communities, that their loved ones will often step up to provide unpaid care. And we know in rural places, especially in the prairies, that there can be a huge range of challenges when it comes to accessing health services. So for example, we know that in rural communities that our health and our services are really shaped by a wide range of different factors. One of the more challenging things that we see is that oftentimes when funding decisions are made or service decisions are made, they're often done with a very city or urban centric lens. And so that means if we're deciding maybe where to build a new hospital or where to put a new service, oftentimes we think about how can we benefit the most amount of people. And that does make sense because we do have finite resources, but it often means that people who aren't living in those big cities are being left out or left behind, or sometimes programs are being copy and pasted into rural areas and they're just not taking into account all the different nuances that come with living rurally. We also know that there are a range of historical challenges to accessing evidence-based healthcare. Things like location and transportation are huge. Culturally appropriate care or the lack thereof can be really challenging. And although there's often this move to maybe telehealth or other virtual services, not all communities are set up with that digital infrastructure to support access to care. So there's still places that don't have high-speed internet or don't have great cell coverage. And so that makes it really hard to be solely relying on these virtual options. And then we also know that more and more services are being centralized to larger areas and being moved out of these small communities. Jen, did you want to add anything on the transportation piece here?
Yeah, I would just, we heard so many times throughout the interviews, and I know like from my own personal working and lived experience that um, like transportation's got to be one of the top barriers for folks. Some participants in this study disclosed to us like having to travel 4 to 5 hours to get their loved ones to appointments. So, I mean, if you're not in a situation where you have a reliable vehicle or any more of the gas money to get to those places, that makes it incredibly difficult to access the care you need. And like I just to go a little bit further, like there really is no detox facilities. Very few, I should say. I shouldn't say no. There's very few detox facilities and other substance use supports rurally. So 9 times out of 10, people are going to have to drive to their nearest, city to access. So it just creates this huge barrier where the person who is using substances has to rely on somebody else. And, hopefully you have a good relationship with that person and there's, been no harm done because you need that person to drive you um, to your appointments. And, a lot of times we heard, the person who is using substances maybe doesn't have a license. Maybe it's been taken away for, various reasons. So it just really leaves that person stuck for options. And we heard it time and time again, and it just hit so hard for me because it's absolutely facts out here that transportation is a huge barrier.
Yeah, absolutely. And very few alternative options for transportation other than relying on that loved one. There's no Uber or Lyft or public transit for a lot of these communities.
Yeah. Alberta has no bus option even to
Yeah,
the city anymore. So really
yeah,
try to do what you need to do.
yeah. And so we're talking a lot about rural. And so one of the big questions that we had as a research team throughout this project was how are we defining rural? And one of the challenging things in Canada is that we don't have a gold standard definition of rurality in Canada. And so depending on who you ask, people will define it in different ways. One way that I like to demonstrate and show people just how rural Canada really is this map from Statistics Canada. And so in this map, Stats Canada says that everything that's gray is considered a rural community or part of Canada. And so geographically, most definitely, Canada is largely rural. In terms of our population, all these little green specks on the map are all urban areas. And so most people in Canada do live in an urban area. They will live in a city. I think it's about 18% of Canadians that live rurally. But what is really interesting to note is that Canada actually has the fastest growing rural population among high income countries. And so more and more people are either moving rurally or they're living rurally. And so it's really important as this population grows that we are spending time and attention trying to understand how can we support the health of people who are living in these communities. And so what does this have to do with substance use? So most people, I'm sure, are aware on this call that we are still going through this toxic drug crisis. And it's a pressing health and social issue across Canada. Since 2016, we know that well over 55,000 Canadians have died from a drug poisoning, and thousands of others have experienced other harms like brain injury, housing insecurity, criminalization. And we know that this crisis is impacting not just people who are using substances, but their friends and family as well. And so there was some research done in Scotland that estimates that for every single person who is using substances or who has experienced a poisoning event, there are 11 people in their network who are impacted. So that's friends or family members. And so if you think about how much that is, if we think about the 55,000 Canadians who have died, that's well over, 550,000 people in Canada who are likely impacted by the loss of a loved one. And so, as was mentioned, as Antoinette mentioned in our little preamble to this, a lot of the public discourse on drug poisoning has focused on these large urban centers. And for a very long time, these places were certainly the epicenter of what we were seeing. But we now know that there is more and more evidence coming out that rural and remote communities are experiencing disproportionate impacts of the poisoning crisis. And so this chart is from the British Columbia Coroner's Service, and it's showing unregulated drug deaths per 100,000 based on health authority. And so on this chart, I've just highlighted the Northern Health Authority, which would be, of course, like the northern part of the province. So thinking about like Prince George, Fort St. James, like that area. And for a long time, Vancouver Coastal, like back in 2015, had the highest drug death rates per 100,000. But as you can see, as time has gone on, it's actually been the Northern Health Authority, which is a much more rural and remote and sparsely populated area that's had the higher drug death rates. And so as of 2026, the drug death rate in the Northern Health Zone is 50.7 deaths per 100,000 people compared to Vancouver Coastal, which is around 32 deaths per 100,000 people. We also know that First Nations people are disproportionately impacted by toxic drug deaths. And so this chart is from Alberta, and we know that due to a history of colonization, discrimination, and racism, that the impacts are just felt so much more acutely among First Nations people. And so in Alberta, the data from 2020 was showing that the death rate was around 7 times higher among First Nations people in Alberta than non-First Nations people. And so I'm going to pass it back to Jen, who's going to talk a little bit about why it's important to be doing harm reduction work in rural places and working rurally.
Sure, thanks, Holly. So as Antoinette mentioned at the beginning of the hour, I have been in this rural harm reduction role with our organization Turning Point for about 7 years. So for people outside of Alberta, this map may not mean so much. For those of us in Alberta, we know just how big this geographical location is. I believe the area that we serve is 90,000 square kilometers. Don't quote me, but I'm pretty sure that's how vast the area is. This program has been operating since 2011 with funding from United Way of Central Alberta, which we are so grateful for. And I must just preface this by saying everything is changing in this role. We no longer have a rural harm reduction program as of November 1st, 2025. I'm staying on to kind of transition. I should tell you why. The government of Alberta has defunded 80% of our operational funding for Turning Point, which is a just huge, devastating hit for the Central Alberta, many Central Alberta communities. We lost our women's program, who supports vulnerable pregnant or parenting women with things like foster care support or labor and delivery, basic needs, birth control, abortion access, anything that kind of goes into reproductive health with women in the central region was getting to be quite a large program. Like the need was definitely there, and it is such a loss to not have that anymore. And just so abruptly, our funding was canceled as well, leaving us very little time to pivot and organize. We're doing it, but it's been challenging. We've also lost our drop-in space, which saw between 80 and 150 people, depending on the season and circumstance. But it was a very busy drop-in space that has been operating for many, many years, decades. So folks in Red Deer now no longer have Turning Point as a place to access support, get harm reduction supplies, food, warmth, basic human needs. So it's been a rough couple months. We are pivoting best we can. So I am still in this role, but we technically don't have a program, and I understand that doesn't make a lot of sense. I'm trying to transition our roughly 15 satellite sites who carried harm reduction supplies and naloxone in their community, because obviously we had 2 workers, so us 2 workers can't be all over this vast area daily or even weekly. So we had strategic satellite sites. Some were pharmacies. We had Rock Soup Food Bank in Wetaskiwin. Family and community support services in several areas, different health centers in Ochese and in Wetaskiwin as well. So we're trying to transition them best we can to get access to the supplies themselves, which is not ideal, but this is where we're at in Alberta, making sure that they're set up as a naloxone distributor. So they're not having to access naloxone from us. They can just do it themselves. And then always like training and support around working with these populations. And as far as like the clients that I see, it's I'm not gonna sugarcoat it. It's been very, very difficult. Upon telling folks who I've been seeing for 7 years that we no longer can come out as regularly, we may have limited supplies, we may not have the supplies that they're used to using, like short tip syringes. We no longer carry those. Yeah, it's been really hard, and people have really dropped off. They're hard to reach. They're feeling abandoned, which I completely I understand those feelings. Yeah, so it's not great. We're doing the best we can to get out to the places that we know, like for instance, have no satellite site. Like Drumheller, for instance, like they do not have a satellite site. We've never been able to interest a community partner to do that work in Drumheller. So like that's an area that I will try to get out to personally to deliver supplies. But it's been tough. People have definitely fallen off, and they assume that there is no support now. So not a great place to be. So what that looks like for me is it's mobile outreach, basically. I load up my car full of harm reduction supplies and naloxone, and of course I'm always available for support. I am somebody with lived experience, albeit I've been in recovery for several years now, but I have walked that path, and I don't know if enjoy is the right word. I'm honored to be a support to people in active use and encouraging, I'm not trying to implement my goals on people, of course, but encouraging them to, be healthier. Here's some other options that maybe you might want to try. Just really trying to support people with whatever they need. If they need to get to a doctor, I'll go with them. If they have no interest in these things and they just start accessing supplies, that's cool. We can just chat, and there's no pressure to go any which way with this program. Yeah, so that's, oh, sorry. We also do a lot of, I should say, a lot of public presentations to organizations, to schools. I've been very honored and humbled to present to maybe about 15, 20 schools over the years. It's been very interesting, traumatic, I'm not sure. Over COVID, we were all of a sudden being asked to come into schools and deliver like realistic drug education to students. And this has ranged from grade 6 to grade 12. And I'll tell you, there's not an audience that humbles and intimidates me more than young students, just because I want to give them realistic, important drug education, but I'm also very careful about what I say, how I say it. I don't want to be accused of normalizing drug use or encouraging students to try. Um, so it's I've learned over the years, like there's a very like tight rope to walk with these things, but what encourages me is when one of the last ones that we did, it was the students union who approached the student or the teachers to have us come in. So hearing that the students want this education and have requested, us Turning Point specifically to come and talk to them, like there is no greater reward in this work. I don't think like it's very meaningful to work with students, also humbling and important. I've gotten into Catholic schools, which kind of boggles my mind a little bit, and very little pushback from parents. Only once that I can recall have parents kind of been like, what is this? What are they talking to my children about? And then after some discussion with the teachers and whatnot, the parents understood the importance of overdose prevention and were fine with it, and actually asked me to come and speak to their parent council at the Catholic schools. So rural work can be incredibly challenging. Like again, not going to sugarcoat it. We face a lot of NIMBYism, misinformation, accusations of enabling. I hear that all the time, but when it gets right down to it, like these, I don't want to say small conversations, but these like intimate conversations or discussions with students, or I've had the opportunity to work with citizens on patrol, which is something I never would have thought. But I can sense like it does make a difference, and you can see kind of sometimes light bulbs turn on in people's brains, like, oh, I never thought of it like that before. And that's all that we can really ask for, is for people to kind of start framing this differently and thinking about it differently. And yeah, presentations have always been, I'm not a good public speaker, as we can probably tell right now, but I enjoy it. And it's so, so important to me. And I can sense change in the communities that I'm in. So honored to do it. Here are some pictures of just me out in the community. There's like we do tabling a lot at different events and like health fairs and stuff like that. So we're always like the party table, it feels like, but we do get a lot of conversation and people coming over, so that's all we can ask for. And then shout out to Nickelback in Hannah. I just have to shout out Nickelback. I'm not sure why, but yeah, I'm very honored to go to these small towns and have the connections that I've made over the years. And that's all. Thank you.
Just a quick question in the chat, Jen. Someone just asked, is there an area on the map that shows as far north as Turning Point would go?
So we go not quite to Leduc, which is just south of Edmonton, but we go to Musquecheese, Camrose, Vegreville, Tofield. So just south of Edmonton is as far north we go. And then we go as far east to the Saskatchewan border, which is a huge area. Right now, we're not doing as much like outreach. So we're doing mail out orders out that way because it's quite a distance. And with the loss of funding, we've lost, mileage and things like that. So unless we're headed that way, it doesn't really, not that it doesn't make sense, but it's easier to mail it. South, we go as far as Drumheller. We had to advocate pretty hard. Drumheller is probably the busiest place that I go, but they weren't part of the United Way funding area. So, and Hannah as well. So we've had to advocate over the last couple of years to include those communities because we are very busy there. And then west, that has typically been another outreach worker that will go west, because I live in Stettler, which is hard to see on there, but it's quite, yeah, thank you. It's far distance to travel. Like it's upwards to 3 hours to go out that way. So somebody who works in the office in Red Deer will head out to Rocky Mountain House or Drayton Valley. So it's a really big area.
Thanks.
Hmm.
Yeah, so the crux of this work, like thinking about our team and the many different lived and professional and personal experiences, living rurally or having substance use experience or supporting a loved one, we wanted to know what are the experiences of unpaid caregivers who are supporting people who are using drugs in rural prairie communities. And so specifically, we wanted to know like what type of care is being provided when these services aren't accessible, what are families' experiences providing this care, how do other structural contexts like policies, stigma, the other things that are kind of happening in our macro environments, how does that shape the experience of providing care? And what types of supports and services are needed to make things better for both families and people who are using drugs? And so I won't go into all the details about this research, but all this to say that this is a community-based partnership that started in 2021. We've worked with a group of 16 other individuals from across the prairies that include academics, family members, frontline workers, and people with lived and living experience of substance use. And the work has been very generously funded by the Canadian Research Institute on Substance Use Matters, or CRISM, Prairie Node. And so we co-designed this research with the Community Academic Partnership over the 5 years. And really, the mantra that we were using throughout is nothing about us without us. And so we really want to make sure that the voices of people who live this were really, really present in the research. The research took the shape of interviewing 31 family caregivers in rural Alberta, Saskatchewan, and Manitoba in fall, winter of 2024. And we were particularly focused on people supporting their loved ones who are using illegal drugs. And so sometimes people were using maybe alcohol, cannabis, or tobacco in addition to using illegal drugs. And we spoke to those family members. But just for the purpose of this project, we weren't interested in really understanding the experiences of just alcohol or just cannabis, just because there's a little bit of a different context right now when it comes to illegal drug use. Jen, was there anything you wanted to add about like the lived experience piece of the research?
Oh, yes. um, it's so important for researchers and academics to really involve the perspective of lived experience and not just, hey, we made a whole project. Would you like to read it over and tell us what you think when the project is already done? So I'm just going to give my roses to Holly because she fully understands the best practices for working with people who use drugs, and we didn't need to catch her up on anything. Inclusion right from the beginning, and even more so with knowledge mobilization, like the opportunities that Holly has given to me and to Reclaim, to bring this project to the front lines, to the people who are living it. It's so important and so meaningful, and I think it just makes this project that much more better, important. Just the way that she's included myself and other members of Reclaim in this, doing the work. And giving me opportunity, like, do you want to do interviews? And at that time, I was quite burnt out. I did not have a good time with the interview process on the last project I did. So I was like, if it's okay, no, I don't really want to do this right now. No worries. Like, we got this, and we'll bring you back in for data analysis. And that's really where my interest is. So I just really appreciate like the options of how would you like to work on this? What suits, like what fits for you to do this? And yeah, I just think that the collaboration between academics and community partners like Mom Stop the Harm as well for this project just made it just so cohesive and like awesome, different. Because I've been involved in many projects where it wasn't quite this way. And we have to spend a lot of our time trying to bring the researcher up to speed on what are the best practices for working with us. We did not need to do that with Holly. So it's just so important for community-based research to actually involve the community and to respect their perspectives and their work. And yeah, there's your roses, Holly.
I did not pass it over to you just for that.
Oh, no, no,
But thank you.
I will say it's not every researcher does that, and it inspired me to do my best work on this project and to take it as seriously as it deserves, because it's I was respected along the way, and it's just I appreciate it so much.
I appreciate that, Jen. And so, who did we talk to? So, we interviewed 31 people. Interestingly, but not really surprisingly, everyone identified as a woman, which I think talks a lot to that gendered aspect of who's providing a lot of care. Most people identified as white, but we did have a few people identify as First Nations or Métis. We spoke to people between the ages of 19 all the way to 68, with most people being around 40 to 59 years old. And most people identified as a parent of someone who's using drugs, but we did hear from people of all kinships and sometimes people who were supporting multiple loved ones. And so sometimes we had someone who was supporting a parent and a sibling. We might have had someone supporting their niece and a friend. And so people were doing a lot of different care work. And we heard from people across all three provinces, but mostly Alberta and Manitoba. And so we invite you to, if you want to learn more about the community report, you can always scan the QR code. We'll also I'll put it in the chat here, a link to the community report as well, if you're interested in seeing more about the findings. And so what did we hear? Well, we started at the beginning. We asked, how did your story of care start? How did this begin? And so a lot of families told us that substance use and care kind of started in the same way. Oftentimes, there were just not enough health and social services that were accessible, available, or even appropriate in their community. And this often started at a very young age. And so, for example, this quote here that we have from a mother in Saskatchewan, she was telling us about her son, who is now an adult and struggling quite a bit with substance use. And she told me, he didn't start using drugs in grade 7, but as time went on, grade 7, 8, 9, 10, his anxiety in school and just for handling things got a lot worse. I think this coping was to self-medicate. And so, for a number of families that we spoke with, they told us about just the challenges of getting access to mental health services very early for their loved one, maybe when they were a child, and the real challenges that their loved ones faced, really in terms of coping with whatever challenge was kind of thrown their way. And so, for many people, beginning to engage in substance use was a coping mechanism for trauma and mental health issues. Oftentimes, it started at a very young age. And we heard a lot about people from families about their loved ones who just couldn't get that support when they were young, when they were in school, and really things snowballed for many of them. And so this really pointed us to the fact that there's a lot of concurrent mental health and substance use issues going on. And really, early intervention is critical, especially in some of these rural communities where you might not even have a family doc, you might not have any sort of mental health supports and services. And so, thinking not only about substance use services, but how do we support the health and well-being of someone in many different facets is really, really critical. We also heard from folks about this sense of this rural ideal. And so a lot of families told us that they felt that sometimes rural communities were viewed as being immune to urban issues, that they were these idyllic, peaceful places, and that substance use didn't happen in. And this was really, really challenging for them as a family member because often it led to stigma in a sense that people didn't believe that there could be substance issues going on. People also spoke to these very rural specific systemic and structural barriers that really prevented them from getting help that they were needing. So, for example, this defunding and then centralizing programs to larger urban areas was a challenge. Maybe really restrictive program eligibility. So, you can't come to this treatment program unless you've been abstinent for 2 weeks, like just things that were really, really not helpful. We also heard from a number of families about systemic racism, especially among Indigenous families. If they had had a previous negative interaction in the healthcare system, that really prevented them from wanting to seek any extra help or services in the future, and the stigma piece as well. And so, this one woman who was supporting her sister in Manitoba just told us that, the smaller the community that you go into, the fewer resources there seems to be. Yeah, so that's my kind of take on the town. I think our housing crisis gets exponentially worse every year. It seems like more and more people are unhoused, and there are just not enough treatment beds available. Wait lists are really, really long, and there's lots of stigma and shame in all communities, but especially in rural communities around substance use. And so we also heard from families that when there were no formal supports or services, or they were really, really hard to access because of that piece around stigma or the appropriateness of what was available, that families often had to come in and fill the gaps. And so the burden of care mostly fell onto families and particularly onto women family members. And often families weren't just supporting their loved ones to maybe go access a service, they were often replacing services, it seemed like, entirely. So, as Jen mentioned, oftentimes there aren't detox facilities in rural places. And so we often heard from families that they were detoxing their loved one at home to try to support them. We also sometimes heard about a lack of harm reduction supports in communities. And so we would have families maybe spotting their loved one who was using substances so that they could respond with naloxone if they needed to, or just ensure that they were okay. We also heard about huge gaps in social services and care. So, like housing, for example. In this quote, this was a woman in Alberta who was providing support for her ex-partner. And she told me, right now, he's living in a trailer in my backyard because he has nowhere to go. We're not together. We haven't been for a long, long time. But he's the father of my two kids, and he got released from jail, and there's no housing, and he had a camping trailer. So I told him he could just stay in my yard. And so stories like this were so common with families stepping in because there were truly no other options in their community. And so it became quite obvious that for most and many families that we were talking to in rural places, that this sort of unpaid care was really the rule and not the exception. If you had a loved one who was using substances and you were living rurally, you would probably be relied on hugely to support them in some sort of aspect of their life. And so, what does care look like? Took the shape of many different things. People talked about just this wide variety of support that they were providing. It could be something like a basic necessity, like shelter or food. Oftentimes, it looked like emotional support. The financial piece was huge. We heard from many people who were providing support for medical expenses, maybe were paying rent for their loved one. Um, just the so Many people talked about this cost of starting over. So maybe moving their loved one to a new place, buying new furniture, new clothing, trying to help them start a new job. Just so much money went into this. Medical support, as I already talked about, people were really providing like medical care to folks and the social support as well, helping them find jobs, helping them maybe apply to go back to school, yeah, tutoring them, like just really helping them through the kind of navigation piece. This one quote was from a mother in Alberta, and she really spoke to the financial piece quite well. She told me that she took out all her RRSPs because she had to pay for a $30,000 treatment program. She paid for that, took out a loan, and then she also had to pay $6,000 worth of fines for her son to get his license back. He had accumulated all sorts of, she called them stupid red light tickets, but we had to get them back. And then the money piece, like she paid a lot for his medication. And this is just was so common, this story. People taking out retirement savings. Some people remortgaged their homes to pay for medical treatment. The financial aspect of this was just mind-boggling, it felt like, when we spoke to people. Jen, was there anything else you wanted to add here around the care that folks were providing?
I think the next couple slides go into what I have in my head. So I'm good.
Okay. And so I think something that was also very interesting was the fact that so many people were caring for the wider community as well. And so care was not limited to the four walls of a family's home. Oftentimes, families were creating networks of mutual aid, advocacy groups, volunteer groups, and in some cases, people were even switching careers completely based on the experience they had had with their loved one. And so this quote was from a mother that I spoke to in rural Alberta, and she had lost her son to drug poisoning and decided to leave her job. And she had quite a well-established career with where she was previously. and she decided she was going to go work in a local shelter instead because she really wanted to prevent this situation that happened to her family from happening to anyone else. And so she told me about her very first day on the job when she was at the shelter. There was a young man who would have been around the same age as her son who had experienced a drug poisoning event. And she saved him. She had an naloxone on her. She was trained. She knew what to do. And later she went to the mother of that shelter resident and she told her, I've lost a son. I wasn't going to lose yours today. And so, although many times it felt like families were sometimes forced into these situations where they had to provide care simply because there were not many other options, for a lot of people, providing care was also very much an act of resistance. And so, if the government wasn't going to be providing support rurally or for people who are using drugs, then at least families could, and they could stand up in a way that said and really demonstrated that their loved ones matter and that supporting other people who are using drugs in the community also matters. And I think something that was just so striking is that caregiving and the burden of care is just so all consuming. And we've truly heard about the significant impacts that families experienced, whether it was emotional and mental strain, like people talked about this increased anxiety, depression, chronic stress. We heard from people who had previous autoimmune issues that were flaring up because of the stress of caring for their loved one. The financial piece, of course, people depleting their savings. Some people had to leave their job to go take care of their loved one. It was just so all consuming. Every aspect of people's lives were touched in some way. Oftentimes, many people would be wanting to rely on friends or family, but the isolation and the stigma also was so challenging for them. And so, as this mother told me, she just said mentally it was really hard. There were a lot of days at work that I wasn't there 100%. And how can you be? There's this chaos happening. He's running from the police and getting arrested, and he's been thrown in jail, or you haven't heard from him. And so, um, truly, people were just, it really felt like every aspect of their life was touched in some way by caring and by substance use. And truly, it just, as we'll talk about in this next piece, just didn't feel like there were enough supports for the family member either. But something I did want to add was that it wasn't just the person providing care or the person using substances who was impacted by this experience. We heard from a number of families about the significant toll on family relationships and dynamics. And so we heard from a number of grandparents who had begun caring for their grandchildren because their child maybe was incarcerated or they had gone into residential treatment or they just couldn't provide the care that was necessary anymore. We also heard from young adults who had been caring for maybe a parent or a sibling who was using substances. And in some cases, these young adults had begun caring when they were maybe 14, 15 years old. And they were now still in this caring relationship when they were 20, 21. We also heard about just the changes in dynamics between family members as well. We heard from siblings who sometimes felt resentful of the other sibling who maybe was getting a lot of attention from the family. We heard about people's romantic relationships being fractured, sometimes because they had differences in how they thought they should be providing care and supporting their loved one. And so, really, just the whole family dynamic and family life and family environment was really flipped upside down because of substance use and the decision to care. And so this quote is from another mother in Alberta, and she was also providing care for her grandchild. And so she told me, like with my daughter, I support her financially with everything. She lives at home with me. I have guardianship of her daughter, my 5-year-old granddaughter, that lives with us. It's like all the emotional support, the mental support, the physical support, giving her housing, making sure she has food. And so I really felt like this person that I was talking to really was able to well describe just the how everyone in the house was impacted, whether or not they were the one providing care or they were the one using substances. It was something that was unavoidable within the household. And yet, so few supports exist for families. We really heard from folks that there are very few formal supports or supports targeted to families. And Oftentimes, even when there are supports available, the stigmatization and criminalization of substance use can be a huge barrier, especially in rural communities where you might not want to show up to a support group if you think maybe your grocery clerk, who you see every day, is going to be there, and they might know a little bit more about you. Sometimes there were a few different mental health supports in the community, but often they might only have one or two free sessions, and then you might have to pay $100 to speak with the counselor per session, or 180. Sometimes there were sliding scales, and so the cost can be so prohibitive as well, especially when you're paying a lot of money already to support your loved one. And a lot of people did rely on informal supports. They were really important. They were oftentimes a really good confidant for people, a place of trust. But they could also be frayed as well. Because care was all consuming and people were spending so much time caring for their loved one, they did sometimes tell us that, my relationship with my friend isn't as strong anymore. I don't know if I really can tell her what's going on in my household. I really want to, but it's really, really challenging. And so, um, as this person in Manitoba who was caring for her sister told us, she really spoke to this kind of fraying of informal supports and just said, there are conflicting views about whether we should have been providing support and what that should look like. I think there are a few people in the family who are real proponents of tough love and no contact. And so, for this woman who had made the decision to care for her sister, other family members kind of said, okay, well, you've made this decision. This isn't us. We're going to leave you to it. And so, really, this isolation piece was really prominent for a number of family members. And so, what would make things better? When we asked in the interviews, tell us about something that would make things better, we really didn't know what families would say. But really interestingly, and I think importantly, families are really clear that they wanted large scale structural change. And so, although individual caregiver supports would be nice, these wide scale, large scale changes are really the things that would be most impactful. So, this would look like reinvesting public dollars in health and social care, community education and stigma reduction, and really just supporting the whole community to be healthy, not just adding these band-aid approaches of supporting the family itself. And folks are really clear that responsibility needs to shift back to the government to be reinvesting in rural public services and supporting and providing this infrastructure to support healthier communities so that this work doesn't just fall on families. But importantly, it wasn't enough just to offer more services in these communities. We really had to make sure that these services were better services. And so that could look like services that are accessible, trauma informed, culturally safe, and especially culturally safe for Indigenous families. That being said, their families did say that obviously it was important as well to offer family-oriented supports, but really without these large-scale, wider changes, families would just be repeating this cycle of needing to support their loved one. And families also recognize that change can't happen without addressing the root causes of substance use. So things like poverty, systemic racism, and colonialism are all central to the challenges that people are facing. And so fixing this is going to require much more than surface level solutions. And it really means dismantling and rebuilding these systems that are continuing to fail rural communities. And so, as this mother in Alberta told us, stigma stops our society and our politicians providing these things because we don't think that mentally ill and people that suffer from some problematic substance use are worthy. That's the bottom line. And until we see that they're worthy and that they are people that contribute, we just need to change everything. And so, the key messages that I hope that you leave with today is that families of people who are using drugs in rural communities are providing substantial unpaid care that is truly important to supporting people who are using drugs. This caregiving is all consuming. It comes at a significant personal and professional cost for many. And despite this, there are so few supports that are available for caregivers and families, particularly in rural areas. And although we do need to augment those supports to provide those really acute supports and programs for families, we also really need these wide scale community and systems level changes if we're going to be moving forward. And so I just wanted to leave with a couple of key recommendations that I think are really important moving forward. I'm happy to answer questions afterwards about some of the work that our team's been doing to really try to advocate for this and push this forward. But we really do need to be enhancing and reinvesting public funding for health and social service delivery in rural communities. Definitely when it comes to evidence-based substance use supports and harm reduction supports, but also in terms of more family doctors, more mental health supports, like really these services that are wide scale for rural communities. We need to be addressing the many different social and structural factors that are creating some of these issues in the first place. So having access to affordable housing, for example, is critical. We need to be super cognizant and be ready to and willing to acknowledge and address the harmful impacts that drug and social policies have on families. We need to be expanding support for all caregivers, with particularly targeted support for families of people who use drugs. And it's crucial that we're developing these community and system level interventions for everyone. And so I just want to thank you so much for having Jen and I in today to present, and we'd be happy to take any questions now.
Thank you. Thanks so much, Holly. I know, hearing, you present and all of the findings, because I'm also somebody that, was part of helping putting this together, but also supports a family, a loved one, a family member. And, it just, I noticed in the chat, a lot of people are saying, yes, I can relate to this. I go through all of this at different points. And so it's what is helpful, I think, is by even doing this and bringing this forward, then we're not alone. Because I think a lot of times people feel like I'm the only one that's doing this because of isolation and stigma and so even putting this out there and the recommendations, I was really wanting to lean into that a little bit. So it's like, okay, so we know this, and what do we do with what we know now? Um, so I didn't see any specific questions in the chat, but I just wanted to, before I ask you to kind of jump into that, because sometimes I think families, and I know for myself, sometimes it's very tiring, um, and it takes its toll, and it's sometimes at the end of the day, I don't even know how, and don't have the energy to even put towards now what. Um, and so I think it's important that as caregivers and families that are supporting loved ones, that we know we're not alone. At the beginning of this, when you started, it shouldn't happen yet. I was still taken back by the how many how many people in Canada are delivering this unpaid care, um, and it really made me pause. Um, and yeah, bringing that to light. I also had popped in the chat, so I don't forget to mention it because we might get going. Is that we do have holding hope groups through Mom Stop the Harm, which are support groups that bring, we often have those conversations within our support groups, and when there is remote or rural communities that are worried about confidentiality, then we have some online groups that people can join, and we've had people do that specifically because they live rurally. And also anybody that's watching this, or we are starting Indigenous Sharing Circle for Indigenous communities to bring their voices together. So Jen, I see your hand is up.
Whoops.
Oh, it wasn't supposed to be?
No, it is. And I just
okay.
I just wanted to amplify, recognize the role that advocacy and connection groups like Mom Stop the Harm have with families. We heard so many times that the virtual option for people to be able to join in whatever time works for them, like there was no pressure, was super helpful. And to be with people that understand the complexities that their lives entail. And a lot of folks, women, did not feel comfortable going to whatever group in person in their communities. So just, yeah, I wanted to shout out to Mom Stop the Harm for offering those virtual supports, because they're so important in rural areas where people are ashamed maybe, or just uncertain of how they'll be received in person. And yeah, I also just wanted to highlight like the isolation piece that you were just talking about, Antoinette. Like I knew this before, but like hearing these stories and going through them over the last few years, it's just a very lonely place. And you think that you can lean on your family, but as Holly said, like sometimes there's differences in caregiving approaches. And so if you can't lean on your supports because of differences in caregiving ways, who do you turn to? And it's just so defeating. But you moms carry on and you support in whatever way you can, and that's just so awesome. And we need that, you know, as people who have gone through it. Like we need those solid supports. If I didn't have my parents, like there's no way I'd be sitting here today. And they're farmers. Like they had no concept of heroin use at the time, and but they held strong that, that's my child, I will do whatever it takes. And without them, like I definitely would not be sitting here. So just, we love you, moms. It's a hard job, and you don't give up. And if anything, you expand your caregiving to include wider community, and that's just so beautiful. So thank you to all the caregivers.
Thank you. Other questions that people might have? Think we are a small enough group that you could pop it in the chat, or you can unmute and ask, just being aware that this is being recorded. So
I have a question. So it's actually kind of two together. So I live in Alberta, and sorry, I have a lot of emotion around all of this. But there's just, as Jen was saying, we're losing so much. And I was just listening to an AFNet research in BC last week, and they were talking about one of the biggest things that is happening with families, that when you're in it for the long term, the long walk, is that we run out of cope. We're flattened. And I see this a lot, and it's heartbreaking because there's just nothing. And so there's that I wanted to ask you about. And although I think all your recommendations are excellent, I can't see that coming into Alberta in the near future. And so your thoughts on that, perhaps. And then the other thing, in rural areas, I've seen, especially people who, have gone through different modes of trying to, I guess, find healing, recovery, whatever words we want to use, and being, not having the experiences that they needed, and suicide being the ending. And just wanted your thoughts on that as well. Thank you so much for your work.
Thank you. And thank you so much for, sharing those questions and thoughts. Like I know that this is such an emotional topic for so many people because of just the sheer amount of emotion and time and energy that goes into being a family member who's supporting someone. And so I do have a few different thoughts that your questions have kind of raised for me. And I think also kind of answer some of Antoinette's questions about, how do we move some of this stuff forward when we're in these really, really difficult times politically and emotionally for so many people. Something that I think comes out strongly to me is the idea of coalitions. And so in many ways, there is power in numbers. Sometimes it's very hard And I get it in the context that we're in right now in Alberta to see, what sort of change is going to happen and how can we move this forward. But I do strongly believe in power in numbers and coalitions in the sense that there's people to pick up some of that energy when other people can't move on. And I say that as someone who's had lived experience caring for someone with a brain injury and some really difficult challenges. There have been times when I had ran out of cope and felt just really like how do we keep moving forward and doing things, but had other people in my network that could pick up for me. And so I see, it's not just families that are in this coalition, but there's academics, there's people on the front line, there's medical professionals, people who are willing to chip away in their own little space to build towards this bigger thing. And that's very abstract, I know, because there's no necessarily tangible thing to say this is happening, but there are many people who care and who are trying to do their best to move things forward. Something that we've been trying to do, and I've been trying to do, particularly with this work, is to think a little bit more creatively and out of the box about, like sometimes it seems like we're not getting a lot of momentum when it comes to moving things ahead in terms of harm reduction and substance use. But how else and who else can we bring into this to move things forward? And so two of the sectors that I've been trying really hard to engage in and have gotten actually some uptake in has been the caregiving sector and as well as the rural health and development sector. And so a few things that I can share that we've been working on and people have taken up some interest in. One has been some discussions with the Canadian Centre for Caregiving Excellence, which is the national family kind of caregiving piece that's working on implementing national caregiving supports and strategies. And so they've indicated that, first of all, they had no idea about anything that families of people who are using drugs were doing. And so having that initial conversation with them, sharing a lot of our work, I've had multiple conversations and we have an open line of communication. That's really important for even just getting this on the radar of some of these larger groups who are doing family-oriented work. The second piece is that rural development piece. And so 2 months ago, I was approached by the federal government, Innovation, Science, and Economic Development. And they are in charge of all rural policies and programming. And so they were really interested in learning more about rural substance use and how to support rural families. And so I've been kind of going back and forth with them as well with some recommendations and things that we could work on from that lens. And so that's not to say that things are going to happen tomorrow, but there are people who are really interested who maybe haven't really been targeted before or brought in into this conversation. And so I think sometimes thinking out of the box or bringing more people in can help when the people who have been fighting for this for so long need to take a step back. So that's what I've been seeing, at least with some different people who are interested. Jen, I don't know if you have any thoughts as well about how to move things forward in these tough times.
Yikes. Not additionally, no. I just wanted to say, like, Holly's take on knowledge mobilization for this project is unlike anything I've ever seen before. Like, she definitely thinks outside the box. She's emailing MLAs and representatives and presenting at rural municipalities conventions, meetings. I don't know. Yes, doing everything I think she can think of to get this on the radar of different people.
Yeah, and I did forget about that. We have had a lot of uptake from the municipalities actually, which is quite interesting, because municipalities are getting shouldered with a lot of stuff that the province isn't picking up or doing. And so we've had some good connections and presentations. We were invited to present to rural municipalities of Alberta, which is there was hundreds of people there. It's all the wardens and mayors from all the rural places across Alberta who were interested in just learning more about substance use, what they can do as a municipality. Alberta municipalities as well, which represents rural and urban municipalities, are also really interested and have been engaging with us around this work. And so there might also be, to that extent, like different levels of government as well that might be able to push some things forward.
Thank you. I think that's really important to bring that awareness to those tables. So, and like you said, have not been invited in and now they're asking questions and having you come in. So, education, I think, is huge, and bringing voices forward so that it's a collective voice. And then I find that a lot of you know, government, rural or, municipalities or, um, provinces or federally, they like the data. They like to look at the numbers. And I really appreciate that you have people's words in there as well. So it's the quantitative and the qualitative. And so when they look at that, it's like, how can you not want to be moved to do something? And so, and having the voice of people that live it to be the voice of what to do. So,
Yeah, and I wish I could, have a report, give it to someone, and then everything is made better. And I know that's not the reality. But please know that we as a team are working every day to, chip away at some of these preconceptions of people who use drugs, of chipping away at these, yeah, the stigma. Like we all try every day to bring new people into the fold so that we can move things forward.
thank you. I'm just noticing the time, so we're
Yeah.
almost out of time. I don't know if there's a quick burning question that anybody has that wants to bring it forward. No. Um, I just want to thank Elder Susie for opening us and holding space with us today in a good way. And thank you to Holly and Jen for all the work that you're doing and that you continue to do. Very important work, very heart-centered work. And Holly, I think, had put in the chat the uh, the project, the findings, and if anybody's interested in having those and wasn't able to get it there, you can also email me, and I can send you the findings. Thanks, Holly just popped it in the chat again. And depending on what kind of device you're in, some people can download it and some people can't. So I think we keep bringing these things forward and keep bringing our voices forward, and then that's how we continue to do these connect sessions collaboratively and working across many levels with um, all sorts of different partners. So we're very thankful for the work that you're doing and that you've reached out and include us at Mom Stop the Harm. And I know that Manitoba Harm Reduction Network was also very heavily involved, and so we just thank you for all the work, and we just keep on working together and supporting each other. So I'm going to stop the recording now.